and then invite everyone in.
Okay, hello everyone. Welcome back to another Monday VMR. It's a jam-packed day where we have, I think, 3 scheduled sessions, and Ravi, always throws in some rapid fires here, rapid fires there. Who knows how many rapid fires we'll have? But we wouldn't have it any other way because we love it so much. But happy to be here today to discuss another case with Alec, and it's a special day for Alec and I. It's our dad's birthday today. So if you ever watch this for some reason, happy birthday, Dad. This is what all your hard work went into, is like Alec and I talking on the internet and not doing anything productive. So yeah, no, excited to discuss a case, and none other than Dr. Sanchez is going to present it to us. But special thanks to Jerome and Simi for helping out with the describing and the teaching points. And so Alec, yeah, I'll pass it to you, and we'll go from there.
Yeah, thanks so much, Austin. Always excited to be here to discuss, and very excited for Andrew's case. I just got off the night, so I'm a little bit delirious, but hopefully this isn't too bad. And yeah, I guess we can maybe start sharing the whiteboard, and then I'm sure Andrew has a twisty-turny case in store for us.
I don't think it would be VMR if occasionally someone was discussing post call. I feel like that's kind of tradition. It's
Yeah, it's more of a for me at my age, it's more of a demerit.
I always felt very delirious after post call. No, it's good to be here. Thanks for having me, guys. I felt obligated to present a case because I actually just had Alec on my own podcast, Diagnostic Atypia, and Austin's actually gonna be coming on sometime too. So I owe it to you guys to present you a case. So whenever the whiteboard's ready, I can start. And also, could I get co-hosts from somebody just so I can share some images a bit later?
Absolutely.
Yes, HLH someone post call CPS bingo. I love that.
And
There
let
we
it be
go.
known that it is Alec's fault if this is a difficult case, because he presented a very difficult case to Andrew on his podcast. So all blame shifts to Alec.
I take all said blame.
Yeah, this is not going to be 9 aliquots. You guys will be okay, I promise. So, okay, aliquot number 1. So, this is a 60-year-old female with a history of MASH cirrhosis decompensated by ascites and hepatic encephalopathy. And she presented to the hospital after a mechanical fall at home. The history was obtained from her husband due to altered mental status. He states that the patient had an unwitnessed fall after the patient had been having a few days of worsening asthenia, as well as what he thinks may be subtle changes to her mental acuity. He says that the patient had been having worsening diarrhea at home, for which she had decreased the frequency of her home lactulose. Other than this, he thinks she may have been eating and drinking a bit less. And her past medical was otherwise notable for just type 2 diabetes and a Roux-en-Y gastric bypass 15 years ago. Other home meds she was on was apixaban, nadolol, pantoprazole, furosemide, and spironolactone. And then on direct questioning of the patient, despite her having altered mental status, she could convey that she was experiencing significant back and bilateral thigh pain on admission, although she's very, very like inattentive and encephalopathic, so she cannot really provide any more details than this. So that's the end of this aliquot.
Okay. What a start, Austin. You want me to go first, or okay? So as a hospitalist, in middle-aged to older women with cirrhosis is not an uncommon presentation that we see. And I think the first thing that I do when I get a patient with cirrhosis is I stop and I take a deep breath, because patients with cirrhosis really scare me. Just because they have a lot of potential complications that can arise from the cirrhosis, and they can come in looking fine and then very soon become very, very sick. Um, so I think the first thing I do is I take take a little bit of a pause, check my own pulse, and then sort of work through the problem like we normally do. So the fall, I'll start with that. So falls, are common as people get older, and we think about all the things in the neural axis that we need to stay upright. And this has been talked about numerous times, but the peripheral nerves, musculature, the vestibular system, vision, neurologic system, so on and so forth. And but I think what's important to define was this truly a fall, or was this potentially syncope? And it sounds like the patient was unwitnessed, was just found by her husband on the floor. So I think once the patient's encephalopathy improves, hopefully, we can gain a little bit more history about what to do. But I think operating under the assumption that there could have been a syncope component and incorporating that into our workup may be a good idea, seemingly because the patient has some risk factors to have potential syncope. Sounds like the patient is on anticoagulation. We're not exactly sure why, so we can clarify that. Does she have AFib? Does she have something else that could have led to this? And it sounds like as well, she hasn't been eating or drinking as much. She's a little bit more fatigued, and then she's also on diuretics. So, and then the people with cirrhosis, as it gets more advanced, frequently can have baseline hypotension. So certainly has some risk factors for significant orthostasis as well. So that's something that I'm just tracking. The history that Andrew provided and was super helpful is about the use of the lactulose. I find it not uncommon and with our patients with cirrhosis that are not feeling well that they come back on their lactulose, and that leads, it's difficult to get up and go to the bathroom that frequently, but at the same time that can worsen their underlying encephalopathy. And so that's just something that we're going to have to track as well, just because in hepatic encephalopathy, it's a chicken and the egg kind of thing. Certainly cutting back on a medication that tries to prevent hepatic encephalopathy can lead to worsening of the symptoms, but at the same time, any acute illness, either the infection, bleed, electrolyte abnormalities, and other things can actually trigger the encephalopathy itself. So although we don't want to place blame entirely on the fact that maybe she wasn't fully adherent to the lactulose, it is something that we're just going to have to continue to track as well. And then the thigh pain, I think I would just have to, wait for the exam on that. Is that just subjective pain? Does she have true weakness on exam, or is this actually asthenia? Does she have tenderness palpation on exam? How long was she down? Does the husband have a sense of that? Could she have some rhabdo or some myositis related to that? And I think, yeah, those are some of my initial thoughts. In regards to incorporating some of the additional past medical history, I'd love to know how well her diabetes is controlled, what her indication is for the anticoagulation. And I think in patients like this that come in with some altermentation, particularly in the setting of any condition that is fairly chronic and debilitating, so decompensated cirrhosis being one of them, but also the Roux-en-Y gastric bypass, by threshold to give empiric high-dose thiamine is very, very low, just because the benefits far outweigh any risk. And so that would be something I would be considering as well. And yeah, I think those are my initial first pass thoughts, but I'd love to hear, Austin, how you're incorporating everything. I also feel like I missed some of the details.
No, yeah, I mean, it's I think you did really well, and it's such a hectic start to a case, but as you said, in patients that have cirrhosis and decompensated cirrhosis, hecticness is sort of the name of the game. And that's why I think it's so challenging to take care of these patients. So I have to say, as we got more history, I honestly kind of ignored the fall. And, we'll come back to that in a second, but I think it seems like, we always talk about defining the background and the foreground, and there's a rich background here. And then I think I think we have two foregrounds, if you will, one of the index presentation to the hospital, and one of the sort of collateral history that we get of that there might be a syndrome that pre-exists the fall, right? And so understanding the time course from Andrew a bit more about the diarrhea, was it that the patient was having more diarrhea because of lactulose that led to her stopping the lactulose, or was it that the patient developed a diarrheal illness with accompanying asthenia, body aches, etc., which sounds very much like an exogenous organism such as a virus that had diarrhea as a manifestation of that, which then led her to stop lactulose, which then led her to have worsening encephalopathy because she has many risk factors for that, as you alluded to. And so I think what I'm trying to do right now is try to establish a sequence of events, so really clarify the foreground, and then try to tackle the fall and its relevance. Because to your point, all we have in our disposal right now is what happened afterwards. We have nothing that happened in the moment as far as that incident event, except for maybe this preceding history that we're getting the collateral from her partner from. So that's where my mind is. I love the pearl about the fall. I think we translate so many things into patient fell, but syncope can certainly be a mimic. And she had a head strike or something on a blood thinner that would also be of concern. So I think always having everything that someone mentions to you on first pass, to consider it as a working diagnosis is is a very good practice. I would say that if you question every diagnosis a patient has, then you're going to really have a really hard time getting through your day. But I have to say a healthy level of skepticism is really important with the job that we do, because certainly I have taken care of many patients that come into clinic that have diagnoses of cancer. Just today, I had a patient that said, oh yeah, they have ILD and that they're on oxygen. And I opened up their last CT report and they have no fibrosis, they have no scarring, they have no interstitial changes. Their PFTs have a low DLCO, but they literally have no clue why this patient's been on oxygen for like 5 years and she's citing 99% on 2 meters. So like having a healthy level of skepticism is important. And so I think right now we just need more information to clarify the sequence of events. So Andrew, excited to hear more.
Yeah, perfect. And just to give you some context and kind of paint a picture of where we were meeting the patient, everything I just gave you in aliquot, what number one is basically kind of like arrival paperwork for a hospital transfer. She had like come from an outside ED to us on a liver service. So, as you all suggested, the notes are not always that detailed, and also it's limited by her altered mental status too. So when she arrived to us, her husband eventually also arrived and could give you some clarifying points on some of this information. So the way he describes the diarrhea, because he's not in medicine, he calls it diarrhea, but it sounds like she was just kind of having like a slightly increased number of like loose stools that would kind of be expected for lactulose, and she hadn't been describing any like infectious symptoms or anything like that. She was just kind of like looking generally like weaker and not eating so much recently. And other than that, it really like caught him off guard that he kind of like came home and found her on the ground actually. So he hadn't really noticed that anything else was kind of off for her. So that's really all I can tell you. Um, on exam, she had normal vitals. Neurologically, she was disoriented and had inattention, as I mentioned, and she did have asterixis. And her abdominal exam, mildly distended abdomen with some ascites, no peripheral edema. Everything else was really unremarkable. But when you're examining her legs for the edema, she's like very tender to like light touch on the thighs, but there are no lesions that are grossly visible that you notice. And then initial labs, she had an AKI, the creatinine of 1.9 from a baseline of 0.7. She had azotemia, the BUN of 24. She had a elevated total bilirubin to 2.2, elevated ALK Phos 137, mildly elevated ALT and AST of 37 and 55, low albumin of 2.3, high INR of 1.7. She had hyperammonemia of 52 micromoles per liter. And then her phosphorus was normal at 3.3. Her CBC, she had a normal white count at 7.3, hemoglobin of 12.6, and platelets of 232. They got a head CT that was normal, and a CT of the back showed a new L1 end plate compression fracture. And that's the end of this aliquot.
Okay, wow. Yeah, rich information. And thank you, Andrew, for going through all that. I guess, Alec, I'll tackle the sort of additional history and the vital signs and then an exam, and I'll leave the lab information to you if that's all right. Okay, perfect. So yeah, Andrew is really nice and really clarified the information. And having transitions of care is something that is very common in the American healthcare system, probably many other healthcare systems. And so being able to piece together information is something that I do every day as a primary care doctor, and having to get records and figure out what's been done, what hasn't been done. And oftentimes there's a lot of gaps in that. And so going back to the patient can be really helpful. But in this day and age, when patient or when disease complexity has become so high, most of the patients that are living today with chronic disease, would not have been alive, 20 or 30 years ago. That's how far medicine has advanced. So it's getting the history from the patients is not always as reliable as we'd like it to be. And part of that's our fault for not being able to educate patients. But the other aspect of this is that, we went to school for a decade or more to try to learn all this language and understanding. So to expect people without that training to understand it is unrealistic. So with that caveat in mind, it seems like there didn't seem to be a preceding illness because the husband as Andrew nicely pointed out, I was like, hey, I was surprised that this happened. It sounds like he understands that she has chronic illness and that she's on medications to manage those things, and that she'll have good days and bad days, as many patients with chronic diseases do. But the fact that he left one day and she was seemingly at her baseline, the next day, and then when he came back, she was had fallen and had declined significantly from a cognitive standpoint, suggests that there's some acuity to this. Now, a subtle tail at the beginning can't be excluded, but it seems like an overwhelming illness wasn't at play beforehand. These are all working hypotheses, because in patients that have the cirrhosis, there's some level of, and especially decompensated cirrhosis, there's some level of immunosuppression at play. And so classic presentations of illnesses may not occur. And so I can't exclude that there wasn't a preceding viral illness or infection of some other kind, but I think that's making that a little bit less likely for me. But that's something I'm going to have to track, and I can't just eliminate that hypothesis at this moment in time. I think what we're really, if we really kind of streamline things and say what has changed, it seems like we don't have enough information about this fall, about what happened. So I just need to translate to what I can objectify, which is the encephalopathy. And so I think we have a nice approach to encephalopathy with the missed mnemonic. Again, we're a little bit uncertain of the time course, but it seems probably not hyperacute, but acute most likely. And we'll have more. So, I think the metabolic, infectious, structural, and toxin is there. I think we're obligated to look for a complication of trauma, but that doesn't seem to be the inciting event just because the patient is on apixaban. Infection, as we alluded to, could be there. Metabolic is probably the main category that would be worried about, and Alec will probably allude to that on the labs. And then infectious structural, I think the time course of that is not so good, but I think we'll have a lot of labs and tests to do, and probably this patient will receive some sort of head imaging unless we garner anything in particular on more blood work. But moving to the physical exam, vitals are normal, which is great. Neurologically, I think there wasn't really anything too unexpected. The patient is having inattention and has a neurologic exam with the presence of asterixis and their cognition that seems consistent with hepatic encephalopathy. But I think that's also a trap because, Alec will reflect on the ammonia a little bit. But I think, there are other things that cause asterixis, and there are other things that cause inattention. And so anchoring on hepatic encephalopathy is not wrong, but if we institute lactulose therapy and don't see a response, very quickly, then we need to shift our diagnostic hypotheses more quickly. That's just a caveat at play. As far as the remainder of the exam, there's no edema, which it seems like one way to interpret that is that the patient is compensated, at least from a volume standpoint. The other thing this could be signaled to with the presence of the AKI, as Andrew mentioned, and Alec will talk about more, is the presence of potentially of hypovolemia. And so that's something that we'll have to reflect on also. And then now we move on to this thigh tenderness. So I think Alec nicely alluded to the potential for rhabdo, which, maybe the labs are reflective of that. We don't have a UA, but I think, that's certainly a reasonable hypothesis depending on how long the patient was potentially down. If I try to make progress on that a bit more, we can say that the patient has, we probably were unable to assess strength just based off the patient's ability to follow instructions for the neurologic exam. I'd be curious to know if the patient was able to get up and walk around or anything like that. But if we just take it at face value and say, hey, the patient is having terrible leg pain, but we look at the legs and we don't see anything, what is the differential diagnosis for that? So I think the superficial aspect of the skin is probably not at play, just because most likely we're going to be seeing something. A deeper soft tissue process like a paniculitis is possible, but usually that will bleed into the superficial surface that we see it, though not always. Like I've seen a few cases of erythema nodosum that can be a little bit more subtle to diagnose. Then we move to the muscle, which certainly is at play, as Alec alluded to before. The bones, also a potential hypothesis why she would have bony pain. We can go down that road if we need to, but that has its own sort of differential diagnosis. The nerves and the vasculature, which exist everywhere, could also, be implicated potentially, though some of those things will leave signal, some of them will not, depending on the particular etiology. So I think, if we don't identify any real lab signature, then seeing if there's a need for imaging will come to mind, and then understanding the neurologic aspect of this, like is there sensory change, is there strength change, are there reflex change, and that might potentially be helpful. But we'll have to try to make more progress on that if possible, understanding that it's incredibly difficult to get a good neurologic exam when the patient can do everything possible to listen to your instructions. So I've babbled on a lot, Alec, but yeah, I'd like to hear your reflections on that, and then your reflections on the labs.
No, that was awesome, Austin. So I love that, and just to highlight a few other like questions I may have for Andrew, like as we move forward throughout the case, and that you sort of touched on is why is the patient on anticoagulation? What's their indication for that? And I think that will just be helpful to frame some of her other medical problems that could play into some part of her presentation, and then also a little bit more of her cirrhosis history. Um, you know, what has she been decompensated in any other ways? Does she have known varices? Has she had an EGD before? The Nadolol, I presume that's for prophylaxis against varices, but is that secondary or primary? And just sort of other, has she ever had a history of SPP and so on and so forth? Because I think those things would be quite helpful to know. And then just testing on the vitals as well. As patients advance throughout their cirrhosis, oftentimes their blood pressure is a little bit on the lower end. So the vital signs are reported as normal, but I'd be curious to know, what the blood pressure actually was. And then also with this potential component of volume depletion, like did we check orthostatics? What are those about? And yeah, those are just some of those reflections on that. But moving on to labs, patient has a pretty significant AKI, and certainly by the history is potentially evocative of volume depletion. And I think for the most part in patient with cirrhosis, the propensity to just have intravascular volume depletion with the underlying vasodilatory state, and also the frequent use of diuretics and medications that give them diarrhea to help their hyperammonemia certainly puts that at the top of the differential. And so I think in that situation, one of the first things we do is just hold the diuretics and then give them some sort of resuscitation back. And we can have a separate discussion about what sort of resuscitation to use at another time. But I think that'd be something that we're probably considering and seeing what happens with the kidney injury after that. Anytime you see an elevated BUN in a patient with cirrhosis, you also have to query the possibility of an upper GI bleed. We don't have any clear history of that otherwise. The hemoglobin seems to be quite appropriate, probably higher than I would anticipate, but we don't know how this patient's baseline, but just something to keep in mind, but probably more related just to the kidney injury in and of itself, and something I would just have to continue to track. The liver chemistry tests overall are like fairly mild. Don't really seem all that unexpected for a patient that's a little bit dry and a patient that has cirrhosis. Even the INR 1.7 could just be explained by the apixaban. I'd be interested to know the patient's baseline INR with the history of cirrhosis. And the hyperammonemia, yeah, oftentimes when patients have cirrhosis, the level of pneumonia doesn't really correlate to symptoms. Like the ammonia could be normal. I'm still going to give this lady a bunch of lactulose to treat likely hepatic encephalopathy. But Robbie in the past, I think, has talked about there's actually different types of hepatic encephalopathy, type A, B, and C, and type C being related to cirrhosis, where the ammonia doesn't really correlate with clinical outcomes or symptoms. Types A and B can. Type A being from acute liver failure, and type B being from like a portosystemic shunt. Yeah, I think in this situation, I really loved how you highlighted that there are other things besides hyperammonemia and hepatic encephalopathy that cause asterixis. So you treat the most likely cause, and then if they're not improving the way that you expect, you give them a bunch of lactose, you confirm with the nurse they're having multiple bowel movements, then you really need to investigate other causes. And certainly worsening uremia could definitely consider that, definitely could cause that as well. And the patients, I would be really interested to know the patient's baseline BUN as well. Is she a lady that's pretty malnourished at baseline, or her BUN is 3, at which point 24, the total number in itself doesn't look all that impressive, but it could be very impressive to her. And then just a reminder that the BUN is just one marker of uremia in and of itself, and like doesn't actually correlate to symptoms per se. So just something to keep an eye on. The lights are fine. So that's good for now. But I think the CBC is very interesting. Most patients that have pretty significant cirrhosis don't have normal platelets, don't have a hemoglobin that looks that nice, and are usually leukopenic if the patient has underlying splenomegaly. So I would be really interested to know the patient's baseline CPC. What's their baseline white count, hemoglobin, platelets? I imagine this patient might be very hemoconcentrated and is falsely elevating some of those things. But I think you give them fluids and then look back at the records if you can get any, and time will tell. But I think that's just something that I'm tracking. In regards to the imaging, the CT head non-contrast, I presume, is normal. So good that she doesn't have a large bleed or anything. It doesn't seem to be clear focality on the exam to warrant other advanced imaging, but we can consider that pending the progression of the case. And we see a new L1 compression fracture. Now, I think my first thought was this may just be explained by the fact that she fell on her back and she's 60 years old and probably has underlying osteopenia, osteoporosis, and maybe some vitamin D deficiency. But I would also be curious to know, I guess we weren't there, so we don't know like how she fell. Did she fall from standing height? Did she like fell off a ladder? What exactly happened there? Was she like trying to clean the top of a refrigerator on the little step stool and fell back like the little grandmas do? So something to keep an eye on. And then the other thought with this weakness that she has is whether or not actually the L1 fracture is new and now she's suffering consequences of this. And she has, neuromuscular compromise because of something going on in her L spine, like either compression of the cauda equina or some radiculopathy or something else. So something we're going to have to keep an eye on. But I agree with Austin that sort of investigating the CK as the first pass would be very interesting, and then getting the urinalysis to compete with that. And then just lastly, before we move on, is anybody with cirrhosis, if they have ascites, they need a TAP, and because it improves the mortality. So it seems like on exam, she may have some ascites, so we really need to stick the probe on there and see if we can pull anything out, just to be sure that she doesn't have SPP, just because 30% or more of people with SPP have no abdominal pain, none. And I've had patients with SPP that are completely asymptomatic, but it can cause very significant kidney injury and has very high mortality. It is not a diagnosis that you want to miss. So something that I would also be investigating in real time as well. But yeah, I think we're still trying to figure out what exactly the problem that we're solving. Is this just a little bit of volume depletion? She gets some lactulose and like she's fine back to her baseline, or is there something else that's going on here? And hopefully we'll get a pivot point here in the coming aliquots. So yeah, Andrew, back to you.
Hold on, I was just going to say, yeah, I think I love your points. And then going back to the L1, if you think about where the dermatomes would be, like if you have a fracture of L1, then the cord and the roots that would be affected below that could correspond like dermatomally to leg pain. So I think something that, again, if we see true weakness as opposed to asthenia, like that's something we're going to have to run on potentially. And then I just saw a tweet from Dr. Tapper today about how a change in bilirubin or hyperbilirubinemia in patients with cirrhosis portends and predicts infection in the hospital. And so if this is a change in her bilirubin status, then the potential for infection we already knew was high, but that's like potential signal. And so I just wanted to share that pearl because I literally just saw that like 5 hours ago. And then lastly, going back to the ammonia, my understanding of hyperammonemia in cirrhosis is that when it's high, like that's potentially consistent with hepatic encephalopathy, but it's difficult to interpret. But when the result is low, then that's actually helpful diagnostically to you. So from what I can recall from the lab, and I'll be interested to know the units in Andrew's lab, but 50 is like relatively lower on the lower side than I would expect. And so if that's truly on the lower end, that would make me question whether or not her presentation was related to hepatic encephalopathy. Again, and my also understanding is that the degree of hyperammonemia like does correlate with hepatic encephalopathy. It's just that, some people will have mild elevations, some people have more elevations, and that's helpful. But the absolute number, if it's low, is actually diagnostically helpful to you. So I'd be curious to know the cutoff of that. And then lastly, for the CBC, I don't know what it is, and I've tried looking this up before a few times, but in my experience in patients with metabolic associated steatotic liver disease, like they very commonly, in my experience, do not have the depth of thrombocytopenia that other liver conditions have. So especially the viral hepatitis. So I have many patients that have this condition, and many of them have normal platelets. And I've tried to look up the mechanism for that, and it's a little bit unclear to me. But it is something that I have anecdotally seen, and there is some support in the literature for it, but I forget the mechanism. So yes, Andrew, tell us more.
Wow, really great discussion. I think everything you all said really captures kind of the core essence of what we do for patients like this with cirrhosis who come in pretty undifferentiated. And before I forget, just something I left y'all hanging on here. For the apixaban, if I remember, this is a pretty old case. I think she had like a portal vein thrombus too, so I left that out of the past medical history. And then I heard a lot of ask for comparing all these labs to prior. I don't have any comparisons for you. I'm sorry. The ammonia is relatively low, as you said, but I'll give you some more information because I think that'll make you more interested in other things. So basically, we hydrate her, as you all said. She sounds like she's dehydrated her. So we gave her a bunch of fluids. We tapped her. She didn't have SBP. And we gave her like very aggressive lactulose. So on hospital day 2, her mental status with like lactulose enemas greatly improved. She can much more clearly report to you that at this time, she's like not super clear on like what was happening at home, but what she knows right now is her thighs are really painful for no clear reason to her. And within the next 24 hours, she then developed non-palpable petechiae on all extremities despite a normal platelet count. And then over the next several days, firm subcutaneous nodules developed over the sites of thigh pain, along with retiform purpura, ultimately ulcerating and forming eschar on top. And she also had tender retiform purpura over the bilateral shins, and I'll show you some photos. So, can you all see that? So this was this petechiae that kind of erupted over the first couple of days, and you'll see on the leg here, you have this retiform branching lesion. This is pretty late, so, several days in now. And there's also a small lesion here. And then let me share one more. Oops. Okay. This is another branching retiform lesion before any significance, kind of necrosis. And that's the end of the aliquot.
Wow. Okay. Maybe I wasn't expecting that per se, but yeah. So I think good to know that what we were sort of hypothesizing for the AKI and the hyperammonemia and all that for hepatic encephalopathy, those things improved, and now we moved on, and we're now getting signal to like the more key problem that we're trying to solve in this case, and this is the muscle and I guess proximal thigh pain that she has, and it seems to be mostly limited to that area from what I understand. And then the development of advancing non-palpable petechiae to retiform purpura to frank, ulceration and eschar formation. So I think just starting with the pain in the thighs, I think, I still the initial proximal fall that she had and being down for a short time, I think certainly she could have had risk factors for rhabdomyolysis, but unless the patient really develops ongoing sort of muscle death and necrosis or swelling in said area where you get sort of localized compartment syndrome, I'm not sure I would expect sort of this retiform purpura essentially to develop. It'd be more of sort of increasing pain, lack of sensation, and then I guess eventually ulceration, but most people would have been caught before that. And Andrew wasn't saying it was like super indurated or firm on exam. We don't have any clear sensory losses otherwise. So I think this problem seems to be primarily in the muscle and then in the blood vessel. So I see the non-palpable purpura. So we know that the platelets are normal. The INR is very mildly elevated, but I'd be interested to see what happens like if the apixaban was held, and if that downtrended to normal or whatnot. So I wonder if there's something in the vessel wall that could be making things fragile, or just something in the blood itself that's causing this. But as this has progressed from non-palpable purpura to retiform purpura to frank ulceration, it makes me really concerned about what's going on in the perfusion of that area, particularly in the arteries and in the veins. We don't get a clear systemic signature of like this patient is grossly hypotensive or septic or in shock or something to really be supporting that. So it makes me think less about a systemic issue and something more localized to the blood vessels in that said area. And we don't get a sense that like there's any of that retiform purpura anywhere else, like only on the lower extremities. So initially when I saw the non-palpable petechiae, I was like, oh, could this patient have, underlying like qualitative platelet issue or, vascular integrity issue, in particular, vitamin C deficiency. I'm not sure how, especially with her bypass history and everything that had happened, if that could be at play. But I don't necessarily think of vitamin C deficiency causing retiform purpura, but that they just may just be a gap in my knowledge. And then, yeah, I mean, I think I would just be investigating from there what other things could cause retiform purpura. I know the CP solvers, including Andrew, have a schema episode on this, but I honestly don't have that memorized yet, so I'd have to be going back to look at that and what's going on there. But I think I would be looking at other parts of the body that see if there's any of these rashes anywhere else. And then I think if we're not getting a signal for like some nutritional deficiency or other infectious etiology, whether or not looking at conditions that could predispose her to hypercoagulability may be at play. But it would be interesting if she was going to develop a hypercoagulable condition while taking apixaban. So that's a known caveat in itself that we would have to explain. And, I would wonder as things progress, whether or not, if we can't figure this out another way, whether it would be a role for a biopsy or something. But I guess what I'm really trying to define at this point is, are these cutaneous findings driven by a more systemic process or a localized process? We're not getting like a hectic like shock syndrome. So I think it's something that if it is systemic, is probably more localized to the vasculature, either in the blood itself or in the vessel wall. But those are my initial thoughts. But Austin, you're a lot better at rashes than me, so help me out, man.
No, I think you touched on it beautifully, and I think the challenge of this case is that distinguishing a local from a systemic process is going to be incredibly difficult just based off the patient's background, and I think that we haven't said that, oh, this patient like decompensated clinically. It's just that, hey, we had this thigh pain, it was persistent, a rash developed, and this rash progressed sort of through the natural progression of retiform to retiform purpura. And so I think what you're doing is you're trying to bring out the schema of like, what does retiform purpura represent? And it's either a vasculitis, so there's inflammation of the usually like medium vessels themselves, or there is basically like a thrombotic manifestation of what's happening. And so from thrombotic standpoint, I'm not sure what happens if we anticoagulate people with DIC, but I think I remember during COVID, we were anticoagulating people and people were still dying of clots and doing all kinds of things. So I think it really depends on like the exact mechanism what's happening. And we know that the targeted forms of treatment for clots do not work particularly well in those that have sort of undifferentiated causes, because we are only attacking one aspect of the coagulant cascade, and there's just so much complexity to it that this is why warfarin is really like the drug of choice, because we just carpet bomb the entire coagulation cascade in order to help them. So I think there's an argument for there being a thrombotic process at play, as you're alluding to, but I think the signal to a vasculitic process is there as a potential connection, because there's an overlap of cirrhosis and certain conditions that can cause that. But then at the same time, there's not an overt like clinical syndrome of like purpura fulminans from like terrible sepsis or like ischemic disease to the liver, like anything that causes the liver to be like in a really rough, like acute on chronically to be in a very rough spot. And so I'm feeling the same tension that you have, but I think I go back to the beginning and say, okay, this patient had a fall. We're invoking that they had a fracture from that, and could that help explain the thigh symptoms? Maybe. And is the rash like a separate phenomenon that we're trying to we're trying to connect together, but maybe they're not. I think that's one tension I have. The other is that, people can get compression fractures and they can be incidentally seen. Like just in clinic last week, I had the same thing. And so it sounds like from the imaging that it's acute and it was new. And we didn't hear about like the level of if it was more than 50% compressed, or if that there was any like central if there was any collapse like into the canal to cause this symptom. So I'd probably be calling a radiologist to ask that, to try to help me make progress. How do I connect these together otherwise? I think again, it's trying to understand like the sequence of events. And I think that's where the real tension is. And then understanding that the systemic aspect to this person's presentation can be very subtle. And so it doesn't exclude it from happening. So right now, I think if we take the vascular phenomenon at its core and we're invoking that there is a true depth to the problem and this essentially ischemia to nerves or muscle, that's driving their thigh pain, then I think to me that argues for a systemic disease, unless they've like clawed it off like more proximally. But probably we would have seen more distal, like frank macro occlusion, as opposed to like micro occlusion, which we're invoking here by the presence of retiform purpura, which implies that there's like a small to medium vessel process going on, right? Versus like a local problem, like does the patient have cryo? Does the patient have like APLS? Like, I mean, yeah, I think I'm still lost. And I think I'm lost because I'm trying to piece together what is something that, do I need to connect all these things together now or not? And I think it's still too early for me to decide because I don't understand the sequence of events well enough yet. So how would I try to make progress in real life? Because I think that's what I like to challenge myself to do. So I would be getting more labs to understand the coagulation system a bit more. It sounds like, we have some of that information. We don't see anything overtly, but to your point, like, is there more subtle things that can be going on, like our qualitative aspects to things that we need to check? Probably checking for the APS serologies, though, they can be challenging to interpret acutely, and I appreciate that. I'd probably be sending cryoglobulins. Because why not, And then I always love to do the academic exercise. And then, I think we want to have a management discussion here and say, hey, like, I don't want this lady to have further progression. Like, I'm going to need help to ask, like, probably, a hematologist to weigh in on what's happening. And then otherwise, I'm going to be looking for infection, even though we're not seeing anything overt. Like, I don't want to miss that. So if we haven't sent blood culture to this point, there's no SPP, fortunately. Like, I will be going down that road. I'd be talking to the radiologist again to understand, can these findings explain her symptoms at all? And then probably talking to, maybe dermatology to understand like what the exact nature is. Maybe we can get a clue to there is a vasculitis versus there is a thrombotic manifestation. Though I think if we've already made that much progress, I'm not sure if the biopsy is going to be able to elucidate the cause. It might just be give you a little bit of non-specific findings. So if we're completely confused after our sort of initial systemic evaluation with blood work and potentially imaging, then at that point, they're probably who I'd ask for help next. But yeah, any final thoughts on that before we pass it back to Andrew?
No, that was amazing, Austin. I love your thought about relating this to the fracture, because I think fat embolism can cause potential like sort of cholesterol emboli and could lead to retiform purpura. Usually you see that more with long bones. But so I don't, if she has one fracture, maybe she has a fracture someplace else that we missed. So I really love that thought. And then just going back to your excellent point in the beginning about a healthy skepticism, I have already just accepted that this is mast cell cirrhosis. Do we actually know that it is? Is it something else that she has that hasn't been diagnosed? And I really, really love all your thoughts about who to call and labs to send. I think the only one I other highlight as well, if we're going to invoke the possibility of vasculitis, is to get a urinalysis just to be sure we're not missing anything there as well. If she's hiding any hematuria or proteinuria, and how we can move that forward. But yeah, I mean, I agree totally with sort of reaching out to the hematology and potentially derm for a biopsy if things are unrevealing, but knowing that the pattern may just be a little bit non-specific unless they pick up cryos or something like that. Yeah, And then I guess as well, just to see if she has a protein gap or something weird, I'd be interested to know the total protein. But I would be interested to see where the case goes next. Tell us, Andrew.
All right, so I'm gonna answer some questions in the chat too. Does she have underlying hepatorenal syndrome? Her renal function got a lot better with all of the fluids, so it was not HRS. And I think you had also asked about distribution of the lesions like elsewhere. There was nothing really significant like above the belly button. Like everything was really in the legs that we could tell. So let me give you, you asked for a lot of things, I'll give you pretty much everything. She had bilateral hip x-rays that showed soft tissue vascular calcifications. Coags were sent, not consistent with DIC. She had no family history of clotting events. She had no stigmata of autoimmune disease. I don't have a UA for you, but I'll say it was negative. She continued to lack fevers or infectious symptoms. I ran a cryoglobulin test that came back negative. Beta 2 glycoprotein 1 and cardiolipin testing were negative. Protein C activity was low, but that was in the setting of cirrhosis, and protein S was normal. There was also low antithrombin activity, but again, that was in the setting of cirrhosis. And for everyone listening, and there was just a fantastic Core IM episode actually on testing for inherited thrombophilias that everyone should check out, as that'll all make sense if you listen to that. So basically, deviating from the real life trajectory of the case for the sake of the exercise, I'm withholding some things from you. So what I'm going to say is, despite 2 weeks of a therapy whose name I'm going to withhold, she unfortunately developed septic shock secondary to wound superinfection. And while she had initially improved with like antibiotics, she unfortunately had recurrent shock. And a CT showed a 7 centimeter abscess underlying one of the necrotic thigh lesions. And despite an incision and drainage and antibiotic broadening, she continued to decline and subsequently passed away after transition to CMO. And this disease really kind of behaved, unfortunately, the way it does. So that's the final aliquot before the final diagnosis.
Oh, I forgot it was my turn because I was so scared. But okay, yes, no, devastating outcome. But I think it speaks again to the severity of her underlying conditions and how that makes her so vulnerable. And so, hopefully, thank you to Andrew for bringing this case so we can continue to learn from it. So, going back to our hypothesis of like thrombosis or versus like vascular issue, I think to have weeks of sitting there doing okay and then develop super infection like argues against the idea that we've missed an infection this whole time. So I think I'm going to table that for now. The only thing I will add into that is I think we saw these lesions. It seemed like retiform purpura, and so I don't have that on my like illness script for this, but I have seen like mimic of like ulcerated lesions in the form of like ecthyma. And so again, I would have expected this person to have more of a systemic signature at some point, but the possibility of ecthyma and its infectious causes, or kind of those what am I thinking of? Uh, like mold infections, like Aspergillus, Fusarium, those sorts of things. Like we wouldn't want to exclude those as a possibility, though I think that's unlikely here. So now we're moving through, and we've done some initial testing. The UA doesn't show signal to a sort of systemic vasculitis that we've heard that we were able to recognize with the UA so far. The cryoglobulins were negative. The APLS was negative. Um, so what does that lead? I think, the curious thing we heard on the hip x-ray was that there were some vascular calcifications. And so certainly, as we get older and develop certain medical conditions, some of which he has, we can see calcifications on x-ray. That's not too uncommon. I have to say, most of the time, unless people have severe vascular disease, like if we heard that she had peripheral arterial disease, or end-stage kidney disease, then I typically see them more distally than proximally, and that might just be a knowledge gap for me, because certainly you can see atherosclerosis proximally, like if you do a CT scan or something like that. But I found that interesting, and with the severity of the lesions, does make me wonder about the possibility of like calciphylaxis. She, especially with the pain that she was experiencing, usually the pain is like from the wound in and of itself. But you'd ask yourself, okay, why would this patient who doesn't have end-stage kidney disease develop calciphylaxis? And the answer is, I don't know, but I do know that there are forms of calciphylaxis that are not related to having end-stage kidney disease. And it's a pretty rare phenomenon, but it is something that has been described, and I have seen one patient with before. I forget the particular circumstances, but if our evaluation to date has been largely negative and we haven't really made much progress, it seems that there's not a clotting phenomenon happening. There's not an infection happening. Then that really leaves like an issue at the vessel itself. And if there's no like systemic vascular disease that we can find, and I guess we haven't heard some of the testing for that, so we'll want like the ANCAs and such just to be like thorough. But if those come back negative, then it would make me wonder about those conditions of the vessel that are sort of antibody negative, if you will. And so I think you could think about like some of the variable vasculitides, but I'm really not familiar enough with the space to be confident in that. But I just know that like severe pain wounds with like eschar, like calciphylaxis, like comes to mind. And if we've sort of eliminated certain possibilities, and this patient has like maybe a more prominent vascular condition than we recognize just by the subtle hint of the calcifications on the x-ray, which is like part of this artificial exercise, then I'm going to run with that. But yeah, Alec, what thoughts do you have?
Awesome. I just love your reasoning and the way that you thought through that. And I think just to highlight your point even more, I think we've watched this patient long enough to know that there wasn't a clear, very sort of hemodynamically compromising systemic condition to cause such profound lesions. And we've interrogated her plasma pretty significantly and have found nothing. And I was thinking, oh, is this purpura NANS, but she doesn't have DIC. And then if we think about the sort of underlying clotting disorders, with the exception of maybe like catastrophic APLS, apixaban, which I assume she was probably continued on throughout this time, like really should prevent any of those clotting issues. So this probably has to be something in the vessel. And we're not seeing any sort of systemic fingerprint of our typical vasculitis syndromes. And the ANCAs, I mean, this is Andrew we're talking about, so he for surely checked the ANCAs, and those were probably negative. So I think the idea of what are something that could be in the blood vessel that's impairing blood flow that isn't treated, doesn't sort of mount an infectious or inflammatory response, and isn't improved with anticoagulation. I think calciphylaxis is an excellent point. I have personally never seen calciphylaxis in patients that don't have kidney disease, but it can happen. And then it seems like she progressed during the 2 weeks. And Andrea mentioned she received an unnamed medication. And I know, unfortunately, that in a lot of patients that have calciphylaxis, they get steroids, which may have been empirically started, that can actually make them worse. And then these wounds just get worse and worse, and then they get super infected, and patients die very rapidly, unfortunately. So with the calcifications on imaging, and I sort of wonder, we don't know what her BMI is. Maybe she had some underlying kidney disease that wasn't necessarily diagnosed, and this acute kidney injury with everything else just sort of tipped her over the edge. But we don't. I don't know. The phos was normal. I don't know. I assume the calcium was normal as well. But I'm wondering if she got a little bit worse with if she got steroids, if that's the medication he's referring to, if that triggered things as well. And so I guess I'm not sure if the diagnosis was made clinically, or if she ultimately got a biopsy, or if this was determined on autopsy. But I think it's been a really challenging case, and it's something that's been really good to reflect on and to think about. I guess the only other thing I thought about was cryofibrinogenemia, but I imagine that was probably negative as well. So I'd be really interested to learn what the FI diagnosis was and what that mystery medication was. But yeah, Andrew, thanks so much for bringing in the case, and let us know.
Yeah, much easier to diagnose in real time. I was just stretching you guys as much as I can. I think it's really impressive how you were able to ultimately put the syndrome together to get to the final diagnosis, because it's a very long list of things that can cause microvascular occlusion, all this stuff. I mean, people are talking about angioinvasive stuff in the chat. You guys are talking about vasculitis, but as you were able to kind of synthesize the story, it was really just like, I mean, she came with the fall, whatever, but she got better and she had thigh pain and she was like fine in pain, fine, fine, fine until like no fevers, nothing like that until really she like wasn't. And then she started like developing infection. So there's really like no other stuff going on. It was just the leg pain. And then she eventually developed the infection. So the way it actually happened in real life was I don't even know how this happened, but a wound RN had like come to see her and had noticed some like duskiness really early on alongside the pain and felt that it was like retiform purpura. And my intern told me that the wound RN was like, "Hey, I think this could be calciphylaxis." I'm gonna be completely honest. I like laughed. I was like, "What?" Like this patient doesn't have ESRD. This makes no sense. And I totally brushed it off. And then as she was following and this thing got worse, I was like, "Oh my God, she has calciphylaxis, I think." So we got dermatology involved very quickly within 24 hours of this really manifesting itself, and they biopsied it, and it showed small vessel calcification and thrombosis that was consistent. So relevant to the calciphylaxis risk factors for her, her parathyroid hormone was 24.1 picograms per mil, 25 hydroxy vitamin D was 30 nanograms per mil. Vitamin C was zero point 0.6 mgs per deciliter, is like borderline low. And we were wondering if that was actually the cause for the petechiae. Someone, I think you all actually mentioned why the petechiae when the platelets were normal. So that may have been at play. Um, and the 125 hydroxy vitamin D was high at 115 picograms per mil. So I have some teaching. Calciphylaxis is a life-threatening syndrome characterized by painful, non-healing skin lesions due to arteriolar calcification and thrombosis, leading to skin ischemia and necrosis. It typically affects patients with end-stage kidney disease when the label uremic calciphylaxis defines the diagnostic endpoint, but non-uremic calciphylaxis refers to this in patients with normal kidney function or earlier stages of CKD. So while non-uremic calciphylaxis is less common than uremic calciphylaxis, it carries a similarly high mortality rate. One systematic review estimated a 52% mortality rate, with the majority of deaths occurring between 2 weeks and 1 year after the diagnosis. And alcohol-associated liver disease is the third most common predisposing condition for non-uremic calciphylaxis. Patients with this due to alcohol cirrhosis are well described in reports, but in MASH cirrhosis, like in this patient, they're actually very much not less they're much less described, which is why we ended up publishing this case. So a little bit about the presentation. It universally presents with painful skin lesions that are often out of proportion to exam findings early in the disease. As in this case, this patient had a ton of pain. You couldn't see anything at first. And that's followed by indurated nodules, ulceration, eschar formation. And then duskiness suggests areas of impending skin necrosis, and retiform purpura and livido racemosa reflect disruption of arteriolar flow. And suspicion should be heightened when the lesions are multifocal and located in areas of rich adipose tissue, as in this case, the thighs are rich in fat, and also the belly. We often see that in patients on the belly. So why this in liver disease? It's kind of unclear. Some people say low protein C and S because of low hepatic synthetic function. You just can't spit out protein C and S. But others basically cite high rank ligand expression and decreased osteoprotogerin, leading to osseous mineral loss and extra osseous calcium phosphate deposition. It's all beyond me, but this is all we found. It's basically not really understood. Um, Other risk factors for NUC, diabetes, female sex, and a history of Roux-en-Y gastric bypass. This was kind of interesting to us because the patient had this Roux-en-Y gastric bypass, and we're not sure if that acted like synergistically at all with her like liver disease to kind of like super predispose her to having this. And regarding treatment, for uremic calciphylaxis, as you all said, it's usually calcium and phosphate derangements that are basically implicated and corrected, but many of these NUC patients, they have completely normal serum calcium and phosphate, just like in this case. So that doesn't explain what's going on. There's nothing to do for that. So this like chelator, IV sodium thiosulfate is used, and that's what we tried in this case. But basically the data for this is like really awful. Like there's some reports that are like, oh, we were successful with this, but in like bigger collections of data, it's really not convincing at all. This just like makes ourselves feel better. Unfortunately, it doesn't really seem to help patients in a systematic way. But great job. This was this was a really hard case actually. I said it wasn't going to be too tough, but it's actually a pretty hard case in the way I presented it, and I think it was a really rich discussion.
Andrew, thanks so much again for taking the time to present it. I'll have to go read your case report that you guys published as well after this. And yeah, I think it was a great diagnostic journey, great teaching, not something that I have ever seen before. And unfortunately, a very tragic diagnosis for which there aren't very many treatments, as you so eloquently discussed. But yeah, Austin, any other reflections before we pass it to see me for teaching points?
No, yeah, thanks so much, Andrew. An amazing presentation. And, I think the way that you arranged the aliquots was, led to a nice discussion and really stretched us. And yeah, I think it's these, these are the diagnoses that you're trying to make, just because, if we had, not to say that we could have really made an intervention that would have changed the trajectory of this patient's course significantly, but trying to recognize devastation before the devastation happens is like one of the biggest goals of clinical reasoning. And so I think if you can recognize cardiovascular collapse before the collapse, like that's a great case. And in this case, unfortunately, there wasn't really anything that we had in our toolbox to modify the patient's trajectory. But I mean, kudos to the wound nurse who was like, hey, I think this patient has calciphylaxis. And, at least maybe being able to have counseling for the patient, or a palliative care, goals of care discussion about, hey, these are the things that we're going to expect. This is what we're going to do. Like that would have potentially been meaningful. But there are many conditions in which like we do have good treatments for, and the early recognition of those difficult diagnoses is one way to make a huge impact in what we do taking care of patients. So yeah, thanks again to Andrew and for describing the teaching points, and then we'll pass it to Simi to do the teaching points.
Thank you, Andrew, for sharing such an interesting case. And I really loved the discussion, Alec and Austin, and I got to learn a lot, and great teaching. And I don't have much to add, but just a brief summary. So first, the patient had altered mental status, and we were thinking whether it is caused by cirrhosis or any medication contributing to it. And about the thigh pain, the initial approach was that it could be either something involving muscles, nerves, or vessels, and we can always see if it is restricted to a particular dermatome. Then, as for the rash the patient was having, we discussed whether it is something local or systemic, whether it be vitamin C deficiency, a platelet defect, or vasculitis. And then we discussed that calciphylaxis can contribute to painful skin nodules, and it may be caused by uremia, but there is also non-uremic calciphylaxis, and is highly associated with diabetes and in people with liver disease. And thank you so much. And I got to learn a lot and really enjoyed today's session.
Wow, Simi, that was amazing. Just like summarizing it so like rapidly and so hyper focused. Amazing job. Yeah, thanks everybody for coming. Stay tuned for the third session of the day later on, and happy CP solving, everyone. Take care.